Okay, I think that's working. So I'll pass over to you, Gregory. And just before I do so, I'll remind everyone of the usual format for these meetings, which is approximately 40 minutes of talking time, followed by up to half an hour of Q&A, and then we'll hand over to Carl for some feedback and comments. And yeah, Greg, if you'd like to start perhaps with an introduction about yourself and your background, that would be
Wonderful.
brilliant.
Well, thank you all so much for your time this morning. I really deeply appreciate it. I know that it's or afternoon your time, but nonetheless, I appreciate it greatly. So just by way of brief introduction, I actually went to medical school back in 1984, so a bit of a while ago, with this explicit intention of being either a neurosurgeon or a psychiatrist, which goes to show you how little you know before you actually go to school, because it's difficult to come up with more disparate personality types or practices of medicine than those two, at least in the US. Um, However, and I went there because I was so fascinated by neuroscience. So Lebet's work had just occurred a year or two beforehand in terms of premotor responses, and obviously Marta Kudis's work on psycholinguistics and event-related potentials. So this idea that things occur in the brain prior to our attentional awareness was fascinating to me, and Marta Kudis's work around event-related potentials with second language learners. So the event related that would show up as she was teaching folks about an incongruent response or an error response that was, in the 300 to 400 millisecond range. So certainly prior to what would normally one might think of in terms of attentional awareness. And I recognize those terms can get kind of tricky kind of quick, so I'll leave it at that. That's what I wanted, because I wanted to heal the mind. That's what I wanted to do. I thought, okay, well, this is the way to do it. And in 1984, we didn't have the even neuroplasticity. Frankly, was a bit of an odd concept. This idea of even stroke therapy or rehab was something that was avant-garde in much of medicine. But I quickly learned that unfortunately we didn't have the tools or capability to help people as much as we wanted to in that particular space. I'll never forget my first encounter with a major depressive with persecutory delusions, and her particular delusion was that God was punishing her. She had been cut up in a million pieces, and that she was individually being burned. And her first words when I walked in the room were, "Please kill me." And this was followed by excruciating cries of pain. And I had done some developing world work, medicine, where I've seen that as kind of a cultural cry. But I, despite my best efforts, and granted, this is a medical student level effort, so I put that caveat there, but I was able to offer her no relief. That I left there shaking, and I took my hat off to the psychiatrist who was the attending, and I said, "Sir, I apologize. When I went into this, I was thinking kind of my surgical mindset of nothing heals like cold blue steel, and you had warned me that this would be a difficult emotional experience, and I didn't appropriately heed that warning." And so I then, of course, did the logical thing and said, well, if you want to study the brain and you want to not have to deal with that every day, go to ophthalmology, because visual science was another interest of mine. And so I was very fortunate to become an ophthalmologist and board certified and did all that. So at any rate, but throughout, there's been this fascination with neuroscience. And towards the end of my couple different careers, I had the opportunity to come to the Defense Advanced Research Projects Agency with a hypothesis that it might be possible to reverse maladaptive neuroplastic changes, and specifically related to warfighter mental health and suicidality. And you can imagine, as the personality type of an ophthalmologist is one that we don't think we're smart enough to be a family practice doctor, because we couldn't understand internal medicine, OBGYN, and pediatrics. And so um, for me to enter into the world of interventional psychiatry was a tremendous leap of faith and knowledge that I really knew almost nothing. And so one of the first things I did was I had a personal event, frankly, that motivated this change. And so I spent a year doing nothing but immersing myself in the literature and coming up with, I hope, a reasonable hypothesis. And then Dr. Friston was kind enough to allow me to speak to this group actually back in 2021, and to say, okay, please let me know if I'm an idiot, because I don't want to spend anybody's time, money going down a road that's not going to be helpful. So that's my introduction briefly. And I've had the last 4 years, had the wonderful opportunity to lead multiple programs in DARPA, specifically focused around the mental health space. And one of the wonderful things about DARPA is phenomenology is not acceptable. So I'd had the opportunity to spend 10 years in applied physics lab doing some work at another point in my career. And anyway, and so I had to have a metric that was really something that we could get our hands around. So today we're going to talk about, I hope, building on the work that we've done before, this idea of active inference in the anatomy of salience, and can we use this idea as precision-weighted predictive failure? And it's a great joy for me to be here. And problem, as I see it, and my assumption that my guess is most of you share, but that psychopathology actually is pathophysiology. And unfortunately, in mental health today, and the thing that brought me to this field was a personal loss of a very resilient young man who'd spent 13 of 17 years deployed in the 20 years of war, and when I came back to this field, I still realized there's still no clinical basis in anatomy or physiology. Our screening tools were completely based on verbal description. There are no biomarkers, not a single thing an emergency room physician can order to help him or her make a decision regarding admission. And then even the nosology itself. This was some of Freed's work back in 2017, looking from the STARS study at depression. And of that, there were 1,030 unique depression profiles, the most common of which hit 1.8% of patients. And when I would talk to my friends here at DARPA, who are all physicists and engineers, they're like, how do you make sense of that? What does that even mean? And of course, they raise good issues. And then finally, in terms of the treatment piece, I think I at least get a bit frustrated at times where I often hear drug efficacy reports talk about responsiveness, but they'll talk about those that are responders. And of those that respond, we have X percentage of improvements. And The Economist did a nice article a few years ago looking at, actually, if you look at the overall distribution, that the vast majority really have no response. And of those that have a significant response, perhaps thrown into 30% and about 10% more than placebo. And so to me, that is a challenge, although with all good intention, that is a limitation of a pre-imaging era nosology. And so the idea of, well, what is possible in medicine, and this was clear back in 1980 when I went to medical school, but we had good cardiac enzymes that could screen for heart attack with beautiful ROC curves, as you see on the lower left. We had nice electrical physiological indicators of damage to the myocardium. And we had treatments that were very, very specific. I'm sorry, I apologize. I didn't mean to advance that quite yet. Now, obviously, the analogy between the brain and the heart, although historically interesting, for a while, obviously people that had dropsy or congestive heart failure were thought to be weak and lacking character, and we just didn't understand things like cardiac output and ejection fraction. I would say we're maybe in a similar place today, at a similar inflection point, where understanding the brain's anatomy, physiology, and how it works better could move us into this era of anatomy and physiologic-based medicine. So the agenda today, we're going to go over just briefly, given this audience, an anatomic physiologic basis for mental health. Talk a little bit about the anatomy and physiology of what I'm going to term, to avoid controversy, subjective experience. Talk a little bit then about this idea of strengthening resilient emotions and nimble cognition through engineering neuroplasticity from 2021 to the present. I won't be going into a great deal of detail of that because we're still ongoing studies and out of respect for my researchers, but we have made some progress in this move towards the challenge of from subjective descriptions to empirical biomarkers. And then what I really came here today was to get all of your thoughts on this tragedy, what I'm calling the autopoietic inversion. And we know that obviously is this drive for any organizing system to sustain life, to maintain above thermodynamic equilibrium. And yet we know that in suicidality, if we think about it, this fundamental, I hate to use the word drive, but we'll say process towards life and approaching life and avoiding death at from the sympathetic responses to our most ingrained salience and psychological responses gets inverted. And if one talks to folks that are experiencing or have survived a suicide attempt and are living with suicidality, what they will often describe, Marshall Lineman's work in dialectical behavioral therapy is very, very useful here, where they maintain this tension And I've heard it described on multiple occasions as, Greg, it's not that we don't want to live, it's just that the pain, it's imagine yourself in a 30-story building and there's a fire and the fire is so intense and the fire is coming into your particular room and you have a choice of escape out the window versus fire. And so, at any rate, we won't spend a lot of time on the clinical aspects of that, but I think there's a real impetus there and importance of what is happening that is creating that subjective experience that makes the cessation of life a preferable alternative. And then if we have time, I'd like just, I'm a natural philosopher at heart, and I do think we can make a biological case for Engel's vision that psychiatry actually has the potential to lead medicine out of the biomedical model into the biopsychosocial model. And I would, with humility, add environmental. So I tend to call it the biopsychosocial environmental being process of life. So without further ado, again, I know this will be familiar to all of you, so I won't need to spend a lot of time on this, but I think it is important that we kind of ground our basis for these potential biomarkers. If we're going to look for synergistic effects, I think we need to look at the scales of anatomy. I think we need to look at the function. And again, this underlying hypothesis that psychopathology is pathophysiology. And physiology is obviously grounded in anatomy. And so when I think about mental health care in general, from a holistic perspective, I tend to think of the macro scale as this wonderful article back in 2021 did, and talking about these are where we develop our quote priors. And obviously understanding in this audience, I don't have to go into a long definition of what those are, but these can be seen with large scale networks, fMRI, EEG, et cetera. And the interesting piece to me was this targets of non-invasive neuromodulation. And this relies on specific Dr. Menon's work in the triple network model of psychopathology, as we'll see in a few moments. But I do think these microcircuits, cortical columns, L5 pyramidal neurons, they're clearly the hardest to access, but the most critical. And I would offer that perhaps the synaptic connectivity in these neurons is part of what implements predictive algorithms. And I would say conscious and unconscious experience or subjective experience. I want to be careful as we don't go too far down the hard consciousness road description today. And then really this unique window that is offered by computational neuroscience, and particularly, obviously, active inference. And then finally, looking at the micro scale as this targeted pharmacology, or maybe mood as, if you will, hyper priors. And I'm not sure if that's a completely appropriate term or not. It's one that I've just kind of please feel to correct me if that's something that doesn't make sense in the world, but it's the way I kind of think about it. And so this synapses, receptors, moleculars, tractable, but again, very non-specific. As we know, most therapy is you try one SSRI, it doesn't work, let's try another, see how that does better. We wait 3 months, we see what happens, and then we go off the medication, and there's not a lot of benefit. And that's not a criticism. It's a deep appreciation for people that are making people better using those methods. But I think the key aspect is it's simply the wrong scale, or it's not a wrong scale, it's an incomplete scale. And so the question is, can we integrate all of these and make real progress towards an anatomic and physiologic understanding, and hopefully anatomic and physiologic cures? So this is something that changed my life. It was 1999. I was a board certified ophthalmologist at this point, and I was still fascinated by neuroscience, and so I kind of kept up with the literature. And a friend of mine asked me if I wanted to get into retinal implants and work with a company that was dedicated to devoting that effort. And it really was this study that, coincidentally, my son was born the same year, that made me not go down that path, because I think Helmholtz was right. I think perception is not immediate, but the result of unconscious inference. And if you haven't seen the Rao and Ballard study, I'm sure probably everyone in this room obviously has, but if not, I'd really highly encourage you to go back and look at that, as, to me, it at least is one of the foundations for this entire predictive coding model. And here we see different images that are blown up to the 100 pixel level, the different bar lengths, the different levels that occur. And most critically, again, I know this is old hat to all of you, but for me at the time, this idea of photoreceptors being turned off once the image was capable of engendering this predictive model of the world, again, Helmholtz's intuition in 1867, by simply pushing on an eyeball and versus moving your head and saying, well, something's got to be going on that's creating some model. And when this study showed that when you inactivated the top-down components, then the photoreceptors stayed on. And so you weren't able to get that nice visual compression that we rely on for models. And so when it's intact, obviously you do. So this for me said, I was skeptical that we would really get to the place where any type of retinal implant was going to be able to give us acuity that we would want, given the lack of ability to generate the top-down portion, if you will, of modeling. So that at least was a critical turning point in my own life. And so fast forward a bit, when we talk about this anatomic basis for subjective experience, I think Suzuki and Larkham did some beautiful work in Cell back in 2020, and these were anesthetic studies looking at particular neurons. And again, I don't want to spend too much time on this because I know everyone here is very familiar, but it was a beautiful, I thought, very elegant study where they kind of cleverly describe their micro periscope, if you will, seen on the left, and we're able to go down and to the pyramidal neurons we've been talking about, and particularly level 5, and how when anesthesia would occur, it would block. I don't know if you all can see my cursor or not. I'm moving it, but if you can't, I'll just kind of walk through it. But between awake and anesthetized, and we could see the distinction that would occur at that level. And then this is over on the far right. See that this idea of cortical feedback and then thalamocortical feedback, how both of those are inhibited as a result of blockage at this particular level of anatomy in the mesocircuit. So I talked to Will briefly, and he mentioned that he works in Dr. Seth's lab, and I had a pleasure of chatting with him on a couple occasions earlier as I was developing this. So I choose the term subjective experience with some perhaps to avoid some of the discussions around what type of consciousness equals what. And I will say that Dr. Tononi has been a great friend of mine and one of my research on a couple of my programs, and I've been fascinated by IT for a long, long time. And so with respect to him, and I hope this doesn't offend anyone on the call, but I, at least in a simplistic way, tend to, because I'm more of a Hegelian, frankly, and I like synthesis, I see IIT as more of a phenomenal consciousness and global neural workspace there more as access consciousness. And we could have a different discussion about that on a different time. But what's critical here is, again, we see the same level of anatomy regardless of which of these two approaches you have, and it makes sense given what we just saw a moment ago in terms of anesthesia and its effect. So I would argue that perhaps this could be more of a false dichotomy with respect to those who've spent their lives in it. I won't weigh in, but again, from just as a perhaps brief overview level, I would say that this anatomy applies to both. And we could have further discussions about what that would mean if interested. But so anyway, I think that's a part of the anatomy. And then obviously this is part of your work. I don't need to spend any time telling you all about what you have done, but this whole idea of the anatomy of inference, and that not only was visual perception, which was what really changed my own view and pathway of the potential for retinal implants, but looking at planning, attention, and movement. Again, we see the same mesoscale pyramidal neuron levels. And this, of course, refers to the neurochemistry as well, which we know has an important role. And this is just taken from straight out of one of you all's papers. So the pharmacology of precision. So we spent some time talking about the mesoscale, and then this is a reminder that the microscale certainly plays an important role. And this is how that microscale plays the important role, or through this neurotransmitter system. And the impacts on our hidden states, the volatility, unexpected uncertainty, precision of beliefs, policies, et cetera, are clearly involved with the neurotransmitter system. And so my call is not that we by any means abandon pharmacology and focus exclusively on non-invasive neuromodulation or anything like that, or exclude cognitive behavioral therapy, but really a holistic approach to all three scales that could be most useful. And this is just kind of one of my favorite little examples. I like to show this just because, again, this is nothing new to all of you, but this idea really, it's very difficult to hold either the duck or the rabbit in your mind for very long. And I would offer that's because you're getting continuously updated error correction that rises to your level of attention, which then makes you see this and repair your model. And an interesting kind of fun exercise you can do yourself that I won't be able to do for you, but to try to say to yourself rabbit and actually see duck. And if you just do that for a couple minutes, or seconds, after a couple minutes, I think it really does drive home this generative modeling idea and the whole error. It's just to me, it's a beautiful example that I think really highlights the importance of this idea of how we create our subjective experience. So moving forward now, I want to. This is where I came to DARPA, and as I mentioned, there was a personal loss, and I went to the literature and I discovered this article by Dr. Miller, Robinaugh, and Knock. If you're not familiar with them, they are leading suicidologists in the U.S. and I would argue certainly prominent in the world, and have thought deeply and long about this idea of suicidality. And they wrote this perspective paper for advancing the understanding of suicidality, the need for formal theory and rigorous descriptive research. And on the left, we see all of the constructs that Dr. Knock put together at the time for these are the things that lead to suicidality, be they the effective constructs of psychological pain or anger, irritability, emotional reactivity, the social constructs of rejection, humiliation, lack of belongingness, the constructive affective constructs of particularly perceived burdensomeness and hopelessness. And in that paper, he said we have to move towards biomarkers. And this, of course, resonated with me as a surgeon. And then, one of the earliest days, you learn that you can't sew what you can't see. And usually that's from a senior resident saying that a bit less politely than hopefully I just did. And so this idea of, well, okay, does neuroscience then have perhaps markers that could be used that could help us identify the negative affect of psychological pain or cognitive effort or value of self? And as he shows here, this between person variability and psychological characteristics that might increase risk. And again, going with good within person variability over time. I think this is a critical aspect. And one of my primary theses is we have to move beyond simple linear machine metaphors and really think of organisms as with constitutive causality and particularly reticular causality, where time plays a role. And if we don't get inside those, then we will never really make progress in this space. And then his work or their work again was this variability of suicidal thoughts or risk of suicidal attempt. And then the behavioral paradigms that might measure psychological characteristics more precisely. So typical dot probe methods, demand selection tasks, his self-attribution or implicit association test, which then of course developed into the brief death association test. This idea of wearable devices to capture physiology. And then this idea of prospection and specificity test. And this was the one that particularly caught my eye, this escape, go, no choice task. When I think back to the folks that I've chatted with who have had this experience and have lived or living with suicidality, it literally becomes that decision. And if we have markers of that, what could we do in this space? And so this fit well with DARPA because again, as I mentioned, we hadn't really done a lot of mental health. We've done a couple earlier mental health studies, but it's not a primary focus within our organization, although there is deep care for warfighters. What then could we do? And so uh, I this is one of these odd things where I literally went to sleep one night just thinking about how do I build biomarkers around these subjective constructs and do something that we could wrap our hands around. And obviously this was informed deeply by Dr. Knox's work. But it really did kind of occur to me that if you think about all of these, they're various combinations of cognitive rigidity and emotional dysregulation. And we have good neuroscience tests to look at those things, not just in mental health, but obviously in dementia, Alzheimer's, Huntington's, a variety of mechanisms for looking at the cognitive flexibility and emotional regulation. So the program that I developed and came out of our earlier conversations was this idea of strengthening resilient emotions and nimble cognition through engineering neuroplasticity. one of the things about being in DARPA in general and DoD in particular is you have to have an acronym that makes sense. So at any rate, that was the acronym, that was the program, and that was kind of the initial idea that I brought forward. And thanks to some good friends and good work at folks at NIH, they thought this, our National Institutes of Health, Mental Health, was perhaps a reasonable venue to pursue, because there's no such thing as cognitive flexopenia or emotional regulopenia. And given the heterogeneity and comorbidities of the existing nosology, I thought it might be an interesting approach to do so. So essentially, we took Dr. Knox and Miller's work around these ideas of particular tests, and then put that together with Dr. Menon's work as a neuroscientist out of Stanford for a long time, looking at this triple network model of psychopathology. And I'm sure all of you are familiar with it, but just as a brief overview, this idea of the Salience network, switching between kind of our internal and external states, our cognitive executive network, how we solve problems, externally directed action, and the default mode network, primarily with autobiographical, time travel, internal modes of really our presence, our existence, and from those, an emergent property of emotional regulation and cognitive flexibility. So this idea that these brain networks are obviously, I would offer, responsible for subjective experience, thinking, feeling, doing, that aberrant organization or activity, connectivity between these would explain many behavioral health disorders. It's obviously not my idea. Dr. Menon's work demonstrated, I think, this very elegantly, and has most recently done so in schizophrenia on a beautiful, beautiful paper that came out in the last couple of years. But then, can we use neuroimaging advances that we've made to see healthy and unhealthy organization? So could we get to the place where we could actually see what we sow and sow what we see? This is one of the other key papers that motivated me to go down this road, was his initial work that came out in 2011. And here again, in a more wire diagram type of approach, we have the top-down components that receive information from sensory data from the limbic, reward, motivation, self-referential, internal value, autobiographical memory, et cetera. And how these three work together to impoverish cognition, working memory, sequential chaining, deficits in self-referential mental activity leading to excessive rumination, poor autobiographical memory, etc. This was the networks that I wanted to see if we could renormalize, and could we see the persistent adaptive neuroplastic change that we know occurs in trauma. PTSD is obviously an issue that, or PTS more appropriately, but that we face in the military quite a bit, and played a role in my own kind of entry into this field. Fortunately, not myself, but the person that I cared about. So anyway, trauma induces this persistent maladaptive neuroplastic change. And I don't think that's a controversial statement at this point. But I would also argue that is, for me at least, irrefutable proof that psychopathology equals pathophysiology. And that we know that altered activity or connectivity in these networks has specific effects. This was a beautiful article from Akiki back in 2017. But looking at changes as part of PTSD for Salience network and increased activity and intrinsic connectivity, resulting in heightened threat detection or hyperarousal. Now we know obviously there's two different types of PTS, but as a simplification, I think this was useful. And reflected impaired default mode, as well as central executive or frontoparietal, whatever your preference is, modulation abilities. And the anti-correlation, obviously, with the central executive network for that frontoparietal aspects, resulting in decreased cognitive deficits, this loss of top-down regulation, and in the default mode, that's disrupted internal mentation or intrusive symptoms, re-experiencing altered sense of self, dissociation. Dr. Ressler and his group recently published a very interesting work demonstrating trauma and the effects on dissociative identity disorder that I think speak to that as well as then fear generalization. So I thought it was at least a reasonable hypothesis that we could make the argument that trauma induces persistent maladaptive neuroplastic change, that psychopathology equals pathology. So perhaps if we renormalized the activity and connectivity in those networks, we might be able to. And by focusing specifically on cognitive flexibility and emotional regulation, again, I highlight that because those are things that we can measure inside and outside of scanners to give us indicators of success, treatment endpoints, hopefully, and perhaps even prediction. So this is what you would have seen if you had applied to my program for Strengthen back in 2022 was when the broad area announcement went out. And basically I said, I have to have some type of neuropsychological test to activate cognitive flexibility and emotional regulation networks. So you see on the left some work from Langley looking at, and this was actually for Huntington's dementia, different types of shapes where you simply do a discrimination and reversal. You make a compound article or compound image, and then you switch that around and ask people to keep track of it. Clearly, it can become a challenging task, not just for folks living with Huntington's, but for any of us if done well and at certain intensities. So the question is, we know we can induce cognitive flexibility and emotional regulation with good neuropsychological tests, and then I want real-time spatiotemporal imaging in order to model individualized networks of cognitive flexibility and emotional regulation. And this would take into account structural imaging, diffuse tensor imaging, to get our high spatial resolution, but then also high density EEG to get our high temporal resolution. And can we do all this together? And can we look at these responses to create a really spatial temporal model of cognitive flexibility and emotional regulation? And then can we use those to actually predict relationships with function? A neurobehavioral model around cognitive flexibility and emotional regulation that would relate to the anatomy and physiology that could be tested by specific stimuli. And then I just invited researchers to come up with synergistic ways that would address these different scales or potential scales for intervention to optimize, again, around the neurobehavioral markers of cognitive flexibility and emotional regulation, specifically not any symptom of mental illness. So the reason for that was obviously the hypothesis, if we improve these things, it will map to symptoms. But given the inevitable heterogeneity and comorbidity of existing subjective descriptions we mentioned earlier, I didn't want that to be the target of my researchers' efforts. And so this was the overall model. We divided it into two different aspects of correlating connectivity response and then interventions around cognitive flexibility and emotional regulation. So this is just one team's approach, and I won't go into a lot of detail of this because we're still analyzing results, but essentially their hypothesis was that if we combined TMS with brief CBT and we leveraged the plasticity that occurs, well known to occur after TMS, obviously, for at least a short amount of time, and then we interleave that with 5 sessions of CBT. So 5 sessions of TMS, 5 sessions of CBT in a day, 6 sessions per day for 5 days total. It is certainly an intensive therapy, but this was the idea. We did some other kind of fancy work, or they did some other fancy work around actually personalizing the TMS parameters based on some prior beautiful NIH work, and then can we accelerate it and get this hybrid effect? So again, testing this synergy between the different scales. So can we get macro scale and mesoscale synergy for response around something that we can actually measure? And some used for our analysis, and again, I won't deal a long time in this particular effort because it's not really why we're here today, but just to kind of give us a sense that this is possible. So using some of Peng's work and this Inscape model to capture individual differences regarding language lateralization, phenotypic characteristics, longitudinal recovery, and the right, I apologize for kind of moving quickly through this, but demonstrates reasonable success in being able to look at this from a dynamic perspective, the time spent in each of these states to get an individual coactivation pattern estimation. And so using that, the team that was working with the interleave CBT TMS model was able to demonstrate these results. And again, these are small n. We're looking at 14 or so folks proof of concept level. So this work has not been done. But demonstrating this link of the mapping between the occurrence rate within these networks and actual clinical changes on a simple PHQ-9. So the baseline of DMN and CFER states were actually inverted, as you can see on the right, and I would say renormalized, that had a physiologic link to a psychological symptom scale. And so that was an encouraging results. And again, these are early results. This is why I have this disseminated. But again, our metric was, can you get an R-squared of 0.6? And as you can imagine, in the clinical world, they almost threw me off the stage. They said, Greg, there's no one in the world that would publish that. And I said, I understand that. But again, remember, we're going after cognitive flexibility and emotional regulation. We're not going after this diffuse, heterogeneous, comorbid nosology that exists. And I think that was a reasonable target for them in terms of to at least suggest causal effect, because then we could justify the mapping and the treatment. And as far as the treatment over on phase 2, 30% of participants exhibit clinically meaningful improvement after 1 week that persisted at least 15% of them at 1 month. And as again, I based that a comparison of pharmaceuticals as kind of the standard, and clearly that's much faster, lasts longer, and persists longer than pharmacology will achieve. And again, early results, early days, but these are patients with major depressive disorder and many of them with suicidality that showed a encouraging and rapid 1 week decrease in symptoms, as well as the brief suicide cognition scale. And again, emphasizing no one uses this scale ultimately, everybody, we use it appropriately, but it was encouraging, I think, to see this reduction at this amount of time. And to date, we're still waiting. We know this isn't going to, we're not going to persist at 100%, obviously, but this is where we're at now. And we're kind of perversely, I guess, looking for our first failures so that we can get some more statistical validity. But nonetheless, encouraging results. And this is the other piece that I think is important. Using the NIH toolkit for objective cognitive performance, we're able to reverse the very, again, neuroscience test that Dr. Knock and his colleagues suggested, and combine that. This Albertella study, if you're not familiar with it, was a group of neuropsychologists who got together and said, what are the most important things that we need to be able to do to function at the highest levels? And I think of this as resilience. And this was for military athletes, et cetera. And again, these same principles are applicable. And so the idea that this was at least proof of support for this engineering persistent adaptive neuroplastic change in patients living with these disorders could be equivalent to resilience. And really shifting the mindset from symptom reduction to resilience as a goal. So we come now to suicide. I don't need to spend a lot of time on this, and I apologize for the US-centric data, but we lost 4 times the number of active duty veterans in the 20 years of war than were killed in action. We lose 1 person every 11 minutes in the States, and our rates are increasing by 36%. Critically, as pointed out here, and this is, I hesitate to call this the low base rate problem, but at least the low base rate challenge of study, is 13 million seriously think about suicidality, and fortunately only 1.6 attempt. However, of those, 40,000 a year die by suicide, and so we have a problem of identifying false positives with most of our screening efforts. And it's non-trivial in terms of the economic impact as well. So the proposal and the discussion for today is this idea of suicide prevention as a clinical, scientific, and technology forcing function to create resilience prevention and precision mental health cures. The specific proposal that I'm looking to do next, and again, this is why I wanted to have you all's thoughts on the validity of this concept, is that highest risk suicide research, defined as those who are admitted for an aborted or interrupted suicide attempt, which we know has a 300 increase fold risk in 2 years following discharge of suicide, does a couple things. Number one, it mitigates this low base rate problem of ideation versus attempt. We have a known population for comparison. My suggestion, perhaps, is this most recent precision psychiatry roadmap that came out just earlier this year. We could kind of force this acceleration because, again, all comers to ERs with this particular condition are heterogeneous, comorbid, makes a very complex challenge for existing nosology and forces us to get into underlying nosology, underlying physiology and anatomy. And this is, again, where I'm seeking assistance. If we were to make these biomarkers actually biomarkers of resilience, could we create the equivalent with longitudinal monitoring, given all the wonderful things we have now in wearables and platforms, et cetera, of a hemoglobin A1C for diabetes, where we get a chronic assessment of how well that system is functioning over 2 to 3 months, as well as a highly sensitive troponin index for acute myocardial infarction, which really gets down to within 2 or 3 hours of changes in the myocardium. You can see this biomarker. And so could we establish, if you will, a normal range? And then additionally push this for what I'm calling transdiagnostic resilience therapeutics. This idea that symptom reduction is not enough. And finally, kind of fulfilling Engel's vision of psychiatry, leading medicine from this biomedical to biopsychosocial. So here's the framing question. Can we predict, heal, prevent subjective experience of suffering caused by life stressors, including trauma, substance abuse disorder, serious mental illness, leading to suicide? And this is my philosophy, but I believe using an activist philosophy, process theory-based, active inference, biology-based biomarkers, and holistic interventions. Can we go across that entire scale, reweight, remodify, renormalize to change this? Because the working hypothesis is that this is a uniquely human phenomenon. There are no clinical models for it. And so we have to look at suffering as emerging from these maladaptive inferences in psychiatry based on, I would offer respectfully, distorted priors, failed error correction that impact perception, emotion, selfhood, and agency that we saw earlier in this deck regarding the anatomy of inference. And that trauma, substance abuse disorder, serious mental illness can induce persistent maladaptive neuroplastic changes in these large-scale networks. But critically here, creating blood-brain behavioral biomarkers of stress and suffering, which fits obviously with the PPR. But again, could we switch that to this idea of resilience, and that interventions could restore these, update the priors, rate prediction errors, reconfigure dynamics, and eliminate these biomarkers of suffering to restore the idea of biomarkers for resilience, to restore agency, meaning, and belonging towards a transdiagnostic biology-based treatment and universal prevention for suicidality. So this was Engel's words back in 1977, his kind of canonical article. I would argue that we are at a place today, largely thanks to the work of many of you in this area, where this is actually, now we can address this with the level of anatomy and physiology. And again, I'm not going to explain your own work to you. I think we all understand the importance of this. And really, this entire article called for this movement towards resilience. And this inactive roadmap to persistent adaptive neuroplastic change and cognitive flexibility and emotional regulation, I would offer that these phenotypes may not need to remain fixed. That if we can impact in meaningful ways cognitive flexibility and emotional regulation, it will enable us to perhaps deal with different environments from the fragile, durable, resilient, or pro-entropic way in a meaningful way. And again, I recognize there's not an arrow on here, and that's probably for a reason. But my question for you all is, do you think that that is something that is possible if we were to indeed be able to engage in inducing adaptive, persistent neuroplastic change in the markers that would enable us to reappraise, to be cognitively flexible, and demonstrate emotional regulation towards allostatic growth? Oops, sorry. People often say to me, Greg, well, you're trying to boil the water. And I will, or boil the ocean. And I will simply say that even as is in Zimmer's work and Northrop and others, this idea of biopsychosocial environmental is actually critical to this whole process. And that every single one of these things here, from stress, sleeping, food, exercise, those are easy things to track. So all of these contribute to brain health as mental health, that we have social interactions, emotional cognition. We have good tests for all of those. We can monitor all of those things. We can monitor stress, sleep, food, and exercise. We can certainly get polygenic risk scores. We can look at genetics. We can look at epigenetics. The interval that we can't really change at this point, at least easily, is discrimination, socioeconomic disparities, and pollutants. But certainly looking at neurotransmitters, cellular stress, microbiome, inflammation, allostatic overload, whole brain modeling, predictive coding. All of these things, to me, I just see potential biomarkers for resilience that are, for the first time, we can collect in the real world, ecologically valid studies. And we have the capability computationally with dynamic causal modeling and other efforts that we could perhaps start to make sense of this. And if we can make sense of it, perhaps we can do something about it. So this is an idea. And then this is just an idea. But the idea is that our current traditional practice, at least in the US, is if you are admitted for a suicide attempt, you are observed, you have an interview, you have one survey, some type of treatment. Perhaps it'll include ketamine, perhaps it won't. It'll be means restricted talk therapy groups. You're sent home, and you have a 300-fold increase higher risk with monthly medication visits and weekly talk therapy. Again, I'm in no way minimizing the importance of the mesoscale or of the microscale or macroscale. These work, they help, but I would just offer that they are perhaps not sufficient. And that if we were to develop a learning health environment with good open science principles, with continuous inpatient, outpatient monitoring of the synergistic interaction of multiple evidence-based modalities across the scales of anatomy and physiology, biomarker assessment at intake for treatment personalization, a decision tree approach tailored to specific presentations. Obviously, one size doesn't fit all. Serious mental illness is very different than existential crisis. This is not a simplistic, but it be an algorithmic, appropriately designed approach to deal with this. But can we then develop a window of persona biomarkers, a normal range for each individual that would allow this rapid implementation, promising interventions, digital tools for assessment, follow-up, and critically outpatient care, this iterative learning environment, and finally this pathway towards optimization. So I would offer that high-risk suicide research is an engineering boundary condition for lack of resilience and a clinical scientific technology forcing function to create brain network-based resilience and optimal performance as a new clinical outcome. That symptom reduction is necessary but not sufficient. That if we target resilience as our treatment outcome across the spectrum of mental illness, we really have the potential, I think, to change the world. And so this is what this would look like. I'm going to kind of go through this somewhat rapidly because I know we're getting close to the end of our time. But initially, you'd have a baseline assessment that would include electronic health records, self-report, behavioral test, voice, language, face, prosody, blood biomarkers, brain imaging. We then make a recommendation to hospitalize or not hospitalize. Imagine the clinician who currently has to make a decision about, perhaps at least in our country, this decision to admit someone against their will because they are a threat to their own life. And that's a very difficult decision. And anything that could be helpful in that, I think, would be appreciated. This idea of active monitoring. So again, reticular causality, suicidal thoughts, affect, voice, language, these same behavioral tests, escape learning, implicit cognition, ERCF, emotional regulation, cognitive flexibility. So this is an ongoing active from the time you walk into the ER to your time that you have in the hospital, which hopefully then this also creates the potential for passive monitoring that would be introduced for everything from heart rate to EDA, accelerometers, call text, GPS, social interactions. Again, this biopsychosocial environmental model, which then moves to the outpatient theater for continuity via mobile sensing. So this idea of a hemoglobin A1C or a highly sensitive, troponin index that we could measure and in real time and track and see where people are at as kind of normal values. So that we then end up with not just recommendations for hospitalization, but perhaps for a treatment endpoint. So nowhere else in medicine are you just discharged based on some subjective description of the pain is less. What if we could give clinicians something that said, your fracture's healed at a significant point, we can put you in a cast and we can let you go home now. Or your pneumonia has cleared enough that it's okay to give you outpatient antibiotics. We don't have to continue with the IV antibiotics. And then again, this ongoing risk is potentially elevated at just-in-time intervention. So this isn't the current method, and again, I with all respect to safety plans, we kind of throw people back out in the ocean with a life jacket. I want to build a scuba suit. I want them to be able to survive despite the trauma and existence of the world that they return to. And I think we're at a place technologically where we have enough understanding, scalable sensors, therapies to make that possible, as well as critically, again, machine learning tools to continuously ecologically valid therapeutic assessments. Therapeutic assessments is another topic we could probably delve into, but I'm going to leave that for now. And then ultimately, again, this optimization of performance, regardless of what the cause. If we optimize performance and flourish, well-being, Tyler Vanderveel's work, to me, should be the patient-centered outcome. And that, again, cessation of symptoms is necessary but not sufficient. So we make recommendations of TMS perhaps plus DBT. We recommend, in another case, ketamine. And then we have this assessment of continuous performance biomarkers. and clinician support that also builds resilience optimization. So here's the PPR we were talking about. If you haven't seen this, it's a great article came out in Molecular Psychiatry this last year. But again, this idea, this categorical diagnosis are based on symptoms. This obviously moves forward. The NIH's RDoc, APA high top approach. This is not particularly new, but I'm thrilled to see this effort of incorporating these different domains of symptoms, behavior, cognition, integrity, cellular, environmental, the exposome, the ability to track all of these things. And my only question is, what if we were to actually use this same roadmap, but it actually became a roadmap to resilient phenotypes? What if we invert this issue and again, make resilience the goal, leveraging all of the rich data that's going to come out of the PPR? So the final question that I have is how could we use this boundary condition of highest risk suicide to save lives and demonstrate the transdiagnostic impact of active inference? And specifically, please, I welcome your thoughts. I didn't have time to get into kind of the underlying evolutionary biology for salience and autopoiesis, but if you would grant me, at least at a theoretical level, that this is an inversion of this autopoietic drive, if you will, for lack of a better term, and that it represents a collapse of the models that are based that inform our approach avoidance decisions at the most fundamental level. And if that collapse is a valid frame, what latent causes, networks, phenotypes matter most across the spectrum from ER, inpatient, post-discharge, that could perhaps be tracked in meaningful ways to give us meaningful information, not just about risk prediction, but about treatment endpoints and about ultimately prevention. And if we could do this, and again, I really would welcome your leadership, particularly Dr. Friston, in how would you apply these ideas that you've developed over these years that, to me, and again, I'm not saying this because we're on the phone together, but you've seen how I've used these for my own tests in the real world based on your principles. If we were to develop something that was SPARTAN is an acronym, as many of them are. This one doesn't exist, and what I just described and what I just showed you is for Suicide Prevention and Resilience Therapeutics Accelerator Network. So how could we use your principles to make this valid, again, if this is even an approach that you think would be reasonable? So with that, I thank you all for your time. I will keep my screen on, so if you have any questions, I can go back, or we have any other questions about some of the biology, we'll go there as well. But with that, I'll pause. I apologize if I went a few moments over, but I wanted to open it up to questions and then hopefully learn from all of you. Is this a viable idea? If so, how would you implement it? Thank you. You're too kind. But
Thank you, Greg. That was a fantastic talk. I really enjoyed that. So much to unpack, and certainly given me a lot to read and think about. And I'm really looking forward to what Carl and anyone else has to say. Okay, brilliant. So we've got a couple of hands up. David, would you like to go first?
Okay, thank you. I think Ian might have been a fraction of a second ahead of me. Does Ian mind? He's muted at the moment, but if he doesn't, I will go.
You can add. I have a short question. Well, I guess it depends. How long is your question?
It's more of a commentary. So if you want to go first with a short question, feel free.
Okay, so thank you for the lovely presentation, Dr. Witkop. My question is this in the direction towards discovering universal optimal physiological conditions across all environments, or finding an optimum for those local environment conditions? I want to draw attention to the environment as well, because wartime conditions, for example, PTSD, like this state of hypervigilance, keeps you alive in the moment.
Correct. Absolutely right. Absolutely right. Absolutely right.
The conditions that
go ahead,
should also, but yes, that's what I have to say.
Thank you, and it's an excellent point, right? And that is one of the things that I couldn't agree with more. That indeed, that an immediate fight or flight response and response to a loud noise is an adaptive neuroplastic change which occurs in theater. The question then becomes when you return home to a different environment, as you allude to, and where you might be sitting playing chess with your son or daughter and a loud noise occurs in the kitchen, and hopefully all of us would have a brief sense of arousal, but would quickly then return to the chess game without much difficulty. But someone living with that persistent maladaptive neuroplastic change now, because it is in a different environment, would be in a full-on fight or flight response and would be unable to continue enjoying that game. So I absolutely concur that there's certainly no attempt on my part, and if I communicated that in any way, that there would be a universal optimization that would involve all environments, that couldn't be further from my intent. It is absolutely recognizing that what an environmental piece would be tailored towards that. And again, yes, I term a significant physiologic response to a loud noise as maladaptive in the context of once one is home, as opposed to in theater. Does that answer the question or the comment?
Yes.
All right.
Okay.
was next? Terry, Will, do you want to navigate for us, or?
Yeah, sure. David, go ahead then. Thank you.
Thank you. First of all, you might be amused to know that my son-in-law is an observer on wildcats and is currently floating around the Far East. So we have, and they have already produced grandchildren. So you have, and I can confirm you have a lot to look forward to.
Oh, thank you.
The second thing is, I think the answer to your question is, I think this is a good idea. I think I have bored this meeting on previous occasions around a view that I have, that well-being is our subjective experience of what I'm going to call model adequacy, what Carl will probably call something far more precise, but I hope I've got the broad outline. And the interesting thing is that if you look at well-being as quantified in things such as health-related quality of life, it's very easy to get to a whole raft of predictive health states that are very much worse than death. And so you have something that might look like an inversion from the outside, but from the inside is very, very accurate. And the example of that poor unfortunate woman with psychotic depression is a really good example about how when you stand in her shoes, you can't actually argue against her point. Our empathy doesn't allow it.
Yes.
My second point was, and that gives you a way of focusing via the generative models that would be generating well-being, what would predict what our HR quals are going to be. My second point was that you're in an excellent situation in the military to explore this, because you have a whole bunch of people whose job includes deciding to end their lives if certain situations regard it. We call some of those things suicide. We call some of those things bravery and give them medals of honor. Nonetheless, they are the same actions, driven differently. And this gives an opportunity to explore those things in a way where depression perhaps ceases to be a confounder. Related to that, and I was going to suggest that you're also in a situation, and here I disagree with one of your comments, that studies on, in particular, dissociation have shown that the presence of core symptoms of PTSD actually reduce military efficiency, don't increase it. So I would disagree with Ian on that. But what's interesting here is that ordinary basic training, let alone special forces basic training, is sufficient to elicit dissociation. And if we interpret that as a failure to accurately integrate sensory information, you've got a potential subjective tool against which to measure biomarkers. And for the appropriate biomarker for your setting, I'd like to suggest the identified victim effect, which has a reasonably well constructed neurobiology underpinning it, can be reliably reproduced, and is a very significant target for training for combat. You've got to improve the IVE towards your peers, so you'll go and rescue them, while reducing it towards your enemy so you can be nasty to them. And then afterwards, it's been correlated with difficulties in reintegration with society generally, which you also talked about, namely the shift, for example, from your closest social network, which is changed in basic training from your family to your immediate peers in a platoon or something like that. That leads to quite significant discombobulation, for want of a better word, when you come back. And that gives you a potential neurobiological focus for what you want to do, while identifying loss functions appropriate to that would enable you to do the kind of modeling within an active inference framework that will give you what you want. At that point, I'm going to shut up.
Oh, thank you very much, sir. I really appreciate it, and I really deeply appreciate the recommendation. It is a great idea. I similarly, there's some work on pain and suffering by de Ritter, looking at the identification of chronic pain, where you has shown some. I think it's and again, just for clarification, I by no means I'm at least did not mean to imply in any way, shape, or form that post-traumatic stress was actually an improvement of performance. I want to be clear in the clinical diagnosis versus this idea of the sympathetic response. But so thank you for all of those comments. I appreciate it, and I particularly appreciate the recommendation around identity and the victimization perspective on that. As thank you. That those are, and it raises actually a question, and it's one of the things that I've thought about in terms of study design. Is that, and I think I might push back a bit on this idea of, while they have the same outcomes, your comment about the equivalency between sacrifice and suicide. And I think that is something that is important, particularly if we look in preclinical models, where we have numerous examples in the animal kingdom, and I wish I had time to kind of go into some more of the evolutionary biology of this, but where sacrifice is made. So it could be ants will explode and different, there's numerous examples of that. But what is not existent in the animal kingdom, other than humans, is this idea of inverting autopoiesis, of actually moving towards death. And you can do, and unfortunately people have done some rather, you can induce stress to the point that one can become a catatonic macaque or macaque. But the whole that self-harm, not self-harm, is undeniable. We know that occurs. But can you, in preclinical models, and to my knowledge at least, that has never been demonstrated, where even with opportunities that a life would be ended. And then I guess the last thing I would say about that is, from a study design perspective, I'd appreciate your perspective on, because I don't want to focus this exclusively on the military. I think first responders, healthcare workers, physicians have a fourfold increased risk of suicidality than the general population, at least in the United States. Is perhaps comparing groups that, to your point, who are considering euthanasia, right? Who, because of an ongoing oncologic process where there is inevitable suffering and the outcome is known, at which point then that the people deciding to make a physician-assisted death, it can be a very logical and rational one, and it might be interesting to explore. And again, this is just, I'm throwing this out for your ideas. I'm not advocating for this, but to compare that emergency room population that after an aborted and interrupted suicide attempt with the population that is considering physician-assisted death, and comparing all of the biomarkers between those two populations to perhaps reflect their modeling, how that might be different, and give us some thoughts on that. Do you have any thoughts about maybe comparing those two populations? You're muted, sir.
I was going to push back on your formulation of suicide
Okay.
because I think that is important here, and that if I can give some examples, Japanese and Chinese culture has the idea of suicide being a desirable outcome to protect the value of the family and the within society as a whole. And Stoic philosophy includes suicide as a valid response to when your life no longer has purpose by your own judgment. In both of those situations, you can see match the model of an internal model of well-being, projecting virtually well below death, but in this case, them being cultural constructions. Now, that does usefully limit it to uniqueness, societal uniqueness, because the depression that we experience clearly relates very strongly to our social environment, whereas animals' misery, they live in very, very different cultures. Regarding a research design, this is the point where I would, in the first instance, throw people open, or throw it to the people who know how to build the computer simulations, because I think actually moving it back to to real people is a second stage. In the first stage, we want to determine what is plausible. That one reason why I was suggesting trying to reduce to an identifiable victim effect. You've got only a few bits of brain you've got to model. Get that done, get that working the way we predict, and then see if the predictions from that model fit what occurs with real people. And the great thing about your position, thanks to basic training, you've got subtle levels of depersonalization suggesting failure. You've got the peculiarity of special forces training, where I read a qualitative analysis on Korean special forces. There's so few studies, you've probably read it yourself, that that these people see themselves as waiting for death. It's going to happen to them in combat, so they don't worry about it anymore. You know, those kind of things could then be built in, and then it's time to start thinking about the hypotheses you could apply in with your in vivo group, which is perfectly suited to this.
Thank you so much, sir. That is an excellent point. Point taken, and you've modified my thinking on that. Thank you very much.
Thank you, David. Alexis, do you have a question?
Hello, I'm just briefly introduce myself. I'm Alexis. I was a PhD student in Carl's lab. I graduated about a year ago. I'm also currently a final year medical student, so I did enjoy your various medical metaphors. So because we were talking about it just now, you wanted to ask about study design, is that right?
Yes, I'm open to any suggestions
Yeah.
that really would incorporate these principles.
So one of the things I was thinking about throughout the presentation is that I think on the surface, at the risk of accidentally sounding condescending, on the surface, suicidality sounds really obvious to define, and you don't necessarily have to define it. But what I've found sort of in practice is that there's a difference in, for example, suicidal ideation without any intention to do anything about it.
Absolutely.
I think right now
Absolutely.
it's called passive suicidal ideation, and actually wanting to do something about it. And I think a potential interesting study design would be to you get two groups of people with, for example, the exact same depression scores, but one group actually has plans and the other group has sort of just thoughts and doesn't. And I would be very, very scientifically and medically intrigued by what exactly the difference is between them, right? Because I think that would be quite interesting. The second thing is that I think if you're looking for a biomarker for specifically resilience, I think a good idea would be to, because you talk about resilience and responding to stress, the same way that, as you know, for example, like oral glucose tolerance tests, or even testing for, you know, unable to process
Stress
gluten.
test.
You
Yeah, absolutely.
you
Yes.
have
Right.
exactly. So I was
Right.
thinking. So my first thought when you said, okay, I want a biomarker in an ideal world, I want a biomarker for resilience. I was thinking, okay, that means you have to stress them, because you're not going to be in any way be able to tell how resilient they are without stress testing them first. So I think that's sort of the framework that I instinctively find it most appealing, and I think that it'd be very interesting to see what would happen if that did. Yeah, that was that.
Thank you. Yeah, I think one of the challenges in this field, and Dr. Foreman, your comments around well-being particularly resonated with me as well. And I have the privilege of working with Dr. Davidson on some of my research as well on some different programs. And his point though is that actually we don't have a good resilience biomarker. Tyler Vanderveel's work at Harvard and looking at the flourishing index is a useful, I think, incorporating biopsychosocial, all the beautiful work that's done from an epidemiologic perspective. And I think that needs to become our goal, by the way. Again, I'm an activist. I think that we have to move to that Engel's vision is necessary. But that the idea of a biomarker of positivity that is not the absence of negativity, if you will, not the absence of a stress doesn't exist. And so another thing that we've been kind of kicking around is the idea of what if you were to test people that are highly resilient already. But I like your idea, Alexis. I think it's a good point about ideation versus attempt. And so yeah, thank you for your comments. I appreciate that.
Oh yeah, also real quick, I just wanted to second what Dr. Foreman said about how there's a lot of about how there's a lot of almost diversity in why people choose to commit the act, and it can be considered honorable, even if for things like, oh, I don't want to burden my family with medical bills anymore. I think it's a really important part of it, and I think it's really interesting and really important to explore as well. So
It
yeah.
is. That is something I've taken away now from this conversation that I did not have at the beginning of it. So thank you very much to you and to Dr. Foreman for that
Thank you for
emphasis.
sharing. It's a great presentation.
Oh, thank you.
Thank you, Alexis. Okay, maybe I can ask one question and then we can hand over to Carl. Yeah, I was wondering, Gregory, whether you had ideas for what is going on in the inferential process with therapies like CBT and TMS. I know at the level of the macro level of CBT, it might be perhaps easier since we can control the observations which are being provided. What is the data which is provided to the brain which concludes it to infer a sense of hopelessness or low self-esteem and so on. Whereas CBT, I imagine, I don't know if anyone's written on it with respect to active inference, but it can be a lot harder to know what the mapping onto the physiology is. I don't know if you've read anything there or if you have inclinations yourself. I'd be interested to hear them.
Well, I think there actually has been some very interesting. So Dr. Siddiqui out of Harvard said done some really beautiful work actually looking at where CBT actually impacts on NMDA receptors and calcium channel. It's quite elegant, and I look at these as again just as a potential example of the slide. I hope that you can see at this point, but from circuits to synapses, and he actually calls these suicidality targets, comparing ketamine or TMS plus D-cycloserine. And D-cycloserine is an old TB drug that's a neuroplastogen. It's off-label for OCD as one of the few things that can help people get past that activation energy. And the inferences, OCD is a fascinating, I mean, again, I think that is a, I didn't want to go down that road today because it's entirely different, but I think what we can do now with deep brain stimulation, as well as non-invasive neuromodulation and neuroplastin effects within OCD, the ability to act against inference or not act because of inference. If you talk to someone that has had to live with OCD and suicidality as a result, they are completely aware that there is no harm in eating, say, X food, that it will not turn into worms and eat them from the outside. I mean, like, they're completely aware of that. I had the opportunity to talk to a PhD astrophysicist from NASA who unfortunately had been debilitated and then fortunately was recovered after some functional neurosurgery approach that wasn't magical, but then it enabled the therapy to work better. So I think that's one of the key things, Will, that I do think it's important to keep in mind that all three scales are critical in inference, and that, but they all do work mechanistically. They all have, I would offer at least that it's ultimately going to be grounded in the physiology. The psychopathology is pathophysiology is kind of one of my primary assumptions, and so that CBT does act, although at a global level. Ultimately, it comes down to the synapse, and ultimately, how that works its way back up the hierarchical chain is a question that my guess is everyone on this call could answer better than I. But I do think that it is absolutely related to this holistic approach to generating models that are informed both allostatically, both interoceptively and exteroceptively. And I'm going to show just one quick other image here. I kind of want to take away from Dr. Kristen's time, obviously, but I think some of the evolutionary biology work is fascinating to really ground us in this idea that there is no distinction at all between brain and body or between central and peripheral nervous system. That when we moved from bilaterians to vertebrates, this idea of reinforcement learning became possible. And these same anatomic structures evolved into the brain, right? And one of my, I'll just show one more little quick thing here to maybe, again, this generative modeling from vertebrates to mammals, but then this idea of stop and simulate versus go and act. I think that these are beautiful examples of generative representations, feedback loop that ultimately determines the decision to stop or simulate or go and act. And this is Bennett's work on cognition, and much similar work. Obviously, you're probably familiar with the basal cognition world. So this whole idea that of a lot of Levin and et cetera have been doing some work in this false dichotomy that we live under, that somehow the brain is different centrally than peripherally, and somehow that's different than the body, and somehow that's different than our interactions with the environment. I truly believe we are biopsychosocial environmental beings, and until we move to that and the reticular causality aspect and jettison our machine metaphors, we'll never make progress, which is a long answer to your short question. But I do think that that it is not only reasonable, but I would argue supported anatomically that CBT will impact the brain at the level of the synapse. But I'll defer to others in terms of thoughts on inferences and models from there.
Thank you. God, it's super interesting. Shall we pass over to Carl now then? If there are no further questions or hands up. I think so. Okay, over to you, Carl.
Is it my turn now?
Yeah, it's your turn. All yours.
Very good. Right, well, yeah, a wonderful presentation and excellent discussion. So many themes covered. You've come to us for very courteously asking for sort of feedback and advice. I'm not sure that we know anything that you don't know. This was a masterclass in holistic approaches, theoretical and clinical, to a very important question. And everything that you said is exactly consistent and coherent with the theoretical neurobiology of active inference. Indeed, this very slide here, the distinction between those things that have intentions and that can plan, here illustrated by simulation. The very capacity to simulate means that you now have access to a world model or a generative model of the consequences of your action in the future, and that suddenly endows things like us with authentic agency, and that does require a different kind of generative model in the brain, in the spirit of the good regulator theorem, and comes along with things like intentions to kill myself, which of course it would be denied any simple reflexive organism or generative model like a thermostat or a virus. But I'm getting a bit distracted. I, I just want to acknowledge you've covered so many themes very expertly. I'm going to just feed back using as a vehicle for the feedback a series of papers that came to mind at different stages in the presentation. Some of them you actually later on turned to and illustrated, but I'll just share them again just to for people, just for point of reference for the other people on the call. To preface the sort of cross-cutting themes and the kind of feedback I thought you might find most useful. First of all, I thought that nearly everything you said comfortably fits with with a understanding of the pathophysiology in terms of neuromodulation and synaptic gain control, which translates in terms of psychopathology to the holding of certain beliefs about what I'm going to do, the kind of thing that I am, or indeed states of affairs in the environment with which I'm engaging, holding those beliefs with undue precision or not enough precision, affording too much precision, confidence to the sensory evidence at hand, a very precise, overly precise likelihood, or an overly precise commitment to prior beliefs. And I think that's important because, just to, again, emphasize your commitment to this fundamental link between the pathophysiology and the psychopathology. I think that the notion of precision and gain control and neuromodulation, be it pharmacological or be it through brain stimulation, or indeed through becoming skilled in terms of mindfulness or your internal attention states or meditation and the like. I think that for that particular mechanistic focus on precision does exactly that job, and I say that because that is exactly the conclusion that one reaches not in suicide research but in schizophrenia research and many other neuropsychiatric ones. So the second sort of thing that's going to stretch my feedback is I can't answer your I can't give you any advice on suicide research. You're clearly much more of an expert than I am. But I do see lots of parallels with schizophrenia research. So what I'm going to do is just highlight the sort of practical approach that have been adopted in schizophrenia research post-study of high-risk suicide cohorts, in the same sense that much of the more telling schizophrenia research sort of looks at high risk cohorts, or people with schizotypical or schizoid personality traits, or people who normal people who score high on these instruments. So I think that's, having an enriched cohort to study is absolutely the right way to go, to have that mechanistic basis, have that dense, continual biomarker acquisition, putting e-health, in the migration from inpatient to outpatient care. I think that's all absolutely the right way to go. And it's the kind of thing that people do aspire to certainly in computational psychiatry, but also psychiatry. And I'll just make the point, of course, that precision medicine takes on a sort of a double aspect. Once, not only is it very precise in relation to personalized medicine, but the thing that makes it personal is the precision with which this person holds their beliefs, and we can leverage that aspect of precision medicine. So we were sometimes sort of played on that notion of precision medicine, possibly disingenuously, but I think you're fully licensed to do exactly the same. Anyway, let me just grab the screen, and then I'll be reminded.
Please, I'll stop sharing, and then you can share.
Okay, lovely.
Would
Yeah,
that be
brilliant.
easier?
Yes, please. So if I can now what do we want? We want the entire screen. Let me just share that. So I noticed at the beginning, some of this is not going to be in order, so forgive me, but if you can just pick out what you found useful, ignore the rest. I noticed that there was very much in the title at the beginning of the presentation that sort of the focus on salience was quite important, and you
Yes.
picked up on this issue, the fundamental mechanistic link between salience and the sort of what underwrites salience. And I've just highlighted this article by Thomas Barber, who's just drawing the distinction between salience in the context of Etienne Baldry's Bayesian surprise. Where should my sniper look to resolve as much uncertainty or maximize information gain, versus attention that is mediated by acting on the inside to increase the precision afforded certain modalities or sensory streams or sources of evidence, be they interoceptive or exteroceptive or indeed proprioceptive. So this is something of a review paper, which
Wonderful, thank you.
Yeah, you've implicitly got the only bit that's relevant for you there, because you then picked out that table from my molecular psychiatry one, which was lifted from a follow-up to this paper. But it's just really supplying more substance to your argument to focus on attention and salience, in the sense that attention, at least, if not salience, can be mathematically described as the allocation of precision in the service of precision medicine for somebody who holds beliefs about themselves with undue precision. So that's that. The other the reason I put this paper up is because you were talking very much about sort of neuroplasticity as a therapeutic intervention, and that struck me as being a very natural argument, in the sense that that if you subscribe to the notion that most of psychopathology is all about investing too much precision in certain high-level prior beliefs about yourself and the world, and in particular the outcomes or the policies that you can simulate. So now we're talking about or authentic agents that can do a simulation and have a notion of the consequences of their actions. That story has been previously pursued from the point of view of both psychopathology and the effects of certain psychedelics, 5-HT2A agonists, by Robin Carhart-Harris under the
Sure.
Rebus hypothesis. Yeah.
Yes. Yes.
He and a number of his colleagues wrote this paper. Have you seen this paper? Am I wasting time?
No, I believe I have, sir. But I'm very familiar with the rebus, but this may be new to me, and I apologize. Thank you very much for bringing this to because I do not recall seeing this precise paper. So thank you very
Yeah, well,
much.
it only came out about a year ago. Again, you don't need to read it, but it does speak to your focus on neuroplasticity as enabling change. So the original rebus hypothesis was just that certain people become stuck in terms of the options that they have in order to deal with a capricious world simply because they have very, very precise beliefs about their options and the courses of actions available to them. And that stuckness, literally getting stuck in a rut, is associated with these high curvature Waddington-like landscapes for us in active inference. That would be a free energy landscape that just keeps you trapped through in a path of least action, so you can't explore other ways of being, other ways of coping with this situation. What he's saying here is that yes, that's really interesting, and it certainly fits with neuromodulate or drugs. Most of the classical ascending neuromodulatory systems, and in particular, his interest here was in serotonergic 2A agonism and psilocybin and other psychedelics, in effectively relaxing those priors and allowing you now to explore other options. So you're not committed to a course of suicide, but there are other ways that you might, that you are the kind of thing that could do something else. What he's saying here is that certainly 5-HT2A agonism will certainly have an instantaneous or over a period, the kinetics allow an effect on relaxing the priors. Is also saying there's another effect which is on neuroplasticity itself. So it's not a direct modulation of synaptic efficacy, but the plastic potential that could endure for several weeks. And then pursuing that notion from the point of view of these Waddington landscapes or free energy landscapes that we carve out for ourselves in from the perspective of canalization. That if we do get stuck in a rut, very much in the spirit that a river carves its own riverbed, we can become um, self-reinforcing, auto-vitiating, and constructing these canals that make us more and more precise. Yes, this is what the kind of thing I am. This is how I respond to this situation. I respond to this situation, and increasingly get locked into a particular mode of response. And just to pick out something that was implicit in a number of points in your presentation, if that particular kind of active inference and behavior is of that pernicious kind that involves avoidance and withdrawal, then you are precluding the opportunity to sample evidence that would challenge your prior hypothesis. So there are particular policies that are self-maintaining and have possibly an autopoietic reversal simply because they are the kind of behaviors that prevent any further learning or any further inference. So you can get this sort of self-canalizing pathology that in principle could be reversed by enabling that sort of neuroplasticity very high. For you, that would be probably, and I forgot to say, of course, the Salience network is the thing that's generating these precisions. It's working out how much precision should I afford to this? How much precision should I afford to that? The plans say in the prefrontal basic ganglia system, but the Salience network, one would imagine, is just in charge of assigning and working out the right precision to afford to this belief or that belief. So I just put this up as, if you like, Rebus 2, but on a slightly longer time scale that speaks specifically to neuroplasticity and the notion of canalization as a sort of universal kind of pathophysiology that has these psychological and behavioral concomitants. That's Carol.
Thank you very much.
You actually referenced this with that little table. I just put this up just again to reinforce the notion that to reinforce the plausibility that this kind of salience, the salience network, salience and precision control in the context of predictive coding formulations of sense-making, decision-making, has enormous explanatory power across psychiatry, from Parkinson's disease through to autism and schizophrenia and the like. I'm just reviewing the evidence for that. So this is a review paper which you've seen, obviously, so we don't need to worry about that too much. Have you read this one by Valerie Krupnik?
I've lost my image here for just a moment here. I apologize. There we go. I'm back.
To Be or Not to Be.
Oh, yes, absolutely. Yes.
I can't remember. I think I might have reviewed it, or if I haven't, then I certainly read it and enjoyed reading it. This is not going to be any useful feedback for you, but it's certainly it begs interesting questions about autopoietic reversal and the imperative to live longer. So strictly speaking, from the point of view of active inference, there is no fundamental drive to live longer. It's the fundamental drive is to behave according to my prior beliefs about the kind of thing that I am. And if I'm the kind of thing that commits suicide, then that's the Bayes optimal way of proceeding, which is a somewhat deflationary approach, but I think does now license this notion. Well, if I am the kind of thing that could commit suicide, simply because that's the less surprising future for me, because I'm one of these things that can simulate a counterfactual future that is conditioned upon my behavior, then it is certainly plausible and indeed Bayes optimal to commit suicide. Because my belief about if I didn't commit suicide, the world was so surprising and uncertain that the committing suicide is probably less surprising and has a lower expected free energy. If that's true, then that kind of belief is only in play because it has been equipped with too much precision. And therefore, if you can relax the precision on that kind of construct, which I repeat, from the point of view of active inference and the free energy principle, is completely plausible with that particular prior belief about or prior self-modeling, that I'm the kind of thing that will be the future without me is going to be less surprising than the future with me living in in it. It also just as a complete aside, it has the same flavor of the meta-hard problem from David Chalmers, that why do philosophers spend so much time puzzling about consciousness, and why is it that we can conceive of philosophical zombies? And I think that the notion that I conceive of a future when I am dead without me in it is a remarkable gift. The very fact that I have the notion of suicide is fantastic, in the sense, literally, it is a fantasy or a hypothesis, which it's a little bit like the hypothesis that I could be me without experience or feelings. I could be a philosophical zombie. Just being able to have these counterfactual hypotheses is quite remarkable. I mean, it doesn't sound very compassionate, but the ability to conceive of suicide, is quite remarkable. It's you won't find that in I repeat, viruses or spiders. Right, so we've seen that one. I just put this back up again, which I'm sure you're aware of, for a particular reason. It was the foundational paper that brought precision to the table in terms of being able to simulate various false inferences, speaking to the positive and indeed the negative symptoms of schizophrenia, using changes in sensory precision and prior precision, and only that, and then demonstrating a lot of the biomarkers and the soft neurological signs could be explained by this, but also the false belief updating and the false inference that underwrites, say, hallucinosis or hallucinations and delusions, and one could imagine also could apply to self-harm and suicidal ideation and indeed behavior. The reason I put this up is that these ideas were developed primarily for explaining psychotic symptoms in schizophrenia, but also to motivate the importance of the electrophysiological biomarkers and other biomarkers you were talking about. So, things like attenuation of the mismatch negativity or violation responses or omission-related responses sort of write themselves as the obvious sort of neurophysiological markers that would attend a failure to either augment or attenuate, say, sensory precision. And the other reason, which is more poetic, for bringing us right back to the primary etiological mechanistic pathophysiology in this line of inquiry applied to schizophrenia research, namely sensory attenuation, is where you started with Helmholtz. So you started with Helmholtz in the sense of, moving my eyes versus pushing my eyes gives me a very different percept. That is, a beautiful take on unconscious inference. But interestingly, it also speaks to saccadic suppression as the primary example of sensory attenuation. So if I can't see the optic flow when I move my eyes, that means I've attenuated the precision of just for about 50 milliseconds, if not less, during my self-made act. So sensory attenuation now becomes center stage as a particular kind of subpersonal salience that the body knows about, or at least the eye knows about, and obviously Helmholtz knew about. So again, you've got this common theme of precision control, of contextualizing your sense making and decision making that is so sensitive dependent again the balance of the sensory precision, the sensory attenuation of the sensory precision, and if you have a failure of sensory attenuation, then you're going to have to respond with an increase in your prior precision, and then we're back to rebus and stuck in a rut, and possibly a dangerous rut that would lead to self annihilation ultimately. Now, in the schizophrenia literature, the first author, Rick Adams here, went off and took this idea very seriously, and largely forgot about the psychopathology and the predictive coding, but really drilled down on the mechanisms of the augmentation and attenuation of synaptic gain that encodes the precision, say, of prediction errors, and try and use not just the mismatch negativity, but a whole raft of paradigms that were all trying to get at failures of this short-term neuroplasticity, a precision control or cortical gain control. In schizophrenia, this is sometimes talked about in terms of excitation inhibition balance. So you were talking about the coupling between the three networks. So
Yes.
that coupling can also be written down simply in terms of the effective connectivity, which basically depends upon the excitability or sensitivity to afferent input, that just itself depends upon excitation inhibition balance. So again, a sort of nice conceptual link between the connectivity or the disconnectivity and the pathophysiology at a synaptic level, which you were implicitly referring to. So that was the foundational one. And then sort of 5 or 6 years later, if not longer, so Rick, the first author, then published this, I think, last year or 2 years ago in Biological Psychiatry, just running through a whole range of putative experiments that you may or may not like and may or may not be relevant for suicide, that produced very consistent empirical results showing that people with schizophrenia, or certainly at risk for schizophrenia, had a very particular failure of precision or gain control in various parts of their brain, and in various populations. So the practical reason I'm showing this is that some of your teams have been using these sort of mesostate models, and I presume hidden Markov models look at transitions between different states. Practically, if
Hmm.
I was working for you, I would complement that kind of descriptive approach with a much more causal approach, using a generative model that's parameterized in terms of the things that you're actually going to be intervening on, which is the synaptic efficacy, and that's called dynamic causal modeling.
Yes.
And that's basically what has been used in this and a number of other studies now. So you can use the same data that you use for the mesostate modeling. You can actually use to do dynamic causal modeling. And I repeat, this is a really practical bit of feedback. The
Thank you.
parameterizations that you're of these models. So for a mesostate model, again, I don't know the work in detail, but I know the basic setup. You're basically looking at transition rates between different sort of patterns or modes of activity. So the parameters now are the parameters of a transition matrix. That's beautiful and fine, and it has lots of information of a descriptive phonological sort about, what's my dwell time in this kind of state, and how likely am I to progress through this? Is there an orbit here? And all that. But this is entirely phenomenological. If, on the other hand, your generative model is actually neuronal populations causing responses in other neural populations on a graph, then the parameters now become the coupling strengths that depend upon your both cognitive, emotional, and intentional state and
Hmm.
your pharmacological state that just are the synaptic efficacies that are being modulated in the precision control or the gain control or the excitation and inhibition balance. So it's a different kind of generative model, but I think it's slightly closer to the mechanisms. It's causal in the sense that you're actually
Yes.
characterizing in terms of the causes, the connectivity itself. Um, so that was the purpose of that, which is a practical point. Oh, this is a completely non-practical point, which was just a courteous nod to your observations about IIT and access consciousness is was it phenomenal? This is a Ned Block thing, isn't it? And global neuronal workspace. You like this paper if you haven't seen it because it's sort of oh no, it doesn't actually deal with IT. No, I'm afraid I don't think this one does, but it certainly speaks to that access and global neural workspace and ignition from the point of view of the free energy principle. So it tries to be sort of reconciliatory and accommodate
Hmm.
all these different theories from the perspective of for active inference, and in particular Chris Field's sort of quantum information theoretic approach. This has subsequently been completely rewritten by Chris, and he's now the first author. Um, but this original version I thought was nice because it sort of it sort of dissolved a lot of the tension between different people's different explanations of the phenomenology and the experience and the consciousness, and in that particular sense. Right. So, yeah, you've already identified this paper, which um, and you probably know more about it than I do because you clearly read it more recently than I have. So that's good. So that was just again emphasizing the importance of getting the priors right, and particularly, although I can't quite remember whether this was foregrounded in Laura's and Galen's work, but being sensitive to changes in conditions. Because if you develop certain prior beliefs and priors about priors, and incidentally, hyperparameters and hyperpriors are perfectly okay. So a belief about a belief is a hyperparameter. So a precision is a belief, a precision about a belief about what I'm going to do next is, can be regarded as
Hmm.
a hyper prior, and very often we use that to describe things, sort of the precision of a belief about something. And also that has nice connections with metacognition, higher order thought theory. You've got beliefs about beliefs in play. And certainly this centers on the precision of certain beliefs, but I think more particularly how you update those hyperpriors or precision beliefs or predictions of precision, for example, especially when the environment changes. Or say you have a traumatic event, and then you go home, to use your response to the question about environmental specificity, um, um, and the contingencies in your social, cultural, eco niche now return to normal. But because you have engaged in a kind of behavior that could be, again, one of these withdrawal behaviors, you don't know that. So there's no opportunity for you now to update your prior. So you're now locked into um, a hyper, a hyper prior where you basically believe that the world is dangerous and uncertain and irreducibly surprising, and you have to adjust to that. And you never learn that the world is actually not like that anymore because you're back home. But you don't know that because you're not seeking the evidence, because seeking the evidence is itself surprising or potentially potentially damaging or well, mathematically surprising. A very similar theme was pursued. Oh, not by that one, was it? Here we go. By Akin Peters with Bruce McEwen. You talked about allostasis. So Bruce McEwen was one of the world's experts on sort of allostatic load, the wear and tear that you get. So this is a very similar discussion of precision, but written by people who had a much greater fluency in terms of the neuroendocrinology. So it's much less CNS centric and much, it was trying to understand plasticity and the molecular biology and pharmacology, not just of neuroplasticity, but how that is coupled to your corticosteroid function and neuroendocrinology more generally. But a very similar story that the rate of leaving yourself in a state of I think the world has irreducible uncertainty in it, and I have to model that kind of world. That's basically the story of this, but it's much more focus on, I repeat, the neuroendocrinology. I mentioned that because you sort of alluded to it. I was wondering whether you were talking about where are we now? Um, so this was a famous biomarker in I think the 1980s that was going to solve depression.
Right.
I think it's got quite a lot of mileage though. Carefully handled nowadays and interpreted nowadays in the context of stress and depression and possibly suicidal ideation. I wonder whether this should go along with a mismatched negativity as part of
That's a
your
great, yeah, thank
yeah.
you. Thank you.
Right, where are we now? So yeah, yeah. I put this up just as a nod to the fact that the affective or emotional aspects of the psychopathology can again be mechanistically linked to precision, and in particular, and specifically in this instance, the hyper priors on precision. This is one of many papers that just emphasizes priors on priors on priors, but the link between the priors upon the priors and the priors in terms of sort of self-modeling and seeing myself model this and how do I feel about that, leading to a phenomenology and affect rest upon this sort of hierarchical structure which this paper builds upon. It's not necessary to understand any of the details, but just the notion that the way that one level of a deep generative model acts upon another level is by adjusting the gain or the salience or the precision of various messages. And for you, that deep generative model would be like the salience network on the top, and then the other two networks below intervening with intervene between the salience network and the sensorium. So that would be the anatomical basis of of these more mathematical constructs. So just to say that there is a story to be told about emotions and affect and valence and what Mark Soames would call felt uncertainty, should you want to tell that story. But just more practically, in schizophrenia research, although it has not been pursued to the extent that it could be pursued, In answer to your question, how would you use active inference to quantify and characterize um, the um, the psychopathology? The answer to that is fairly straightforward in principle. I repeat, this has not been pursued as much as I would like it to be pursued. The best people using this kind of technology will be found at the Laureate Institute in the States, and particularly Ryan Smith.
Okay.
And right, sorry, what I'm talking about is actually what I'm saying is that if you wanted to use a formal understanding of active inference to phenotype in the spirit of personalized medicine this person at intake for assessment of suicide risk, what you would want to do is, first of all, conceptually appeal to something called the complete class theorem, which we can forget about for the moment, other than to note that for any given person and any given choices that they make in the face of a particular task, paradigm, or evidence, there are some set of priors that render their behavior base optimal. That means that if you think people behave and sense make and decision make under active inference, i.e., the kind of bounded rationality you get from active inference, that means that you can describe anybody in terms of active inference in terms of their prior beliefs. And of course, if you know their prior beliefs, the most interesting aspect of their prior beliefs is the precision of those beliefs. Do they believe that they will win 5 times more than they will lose, or how confident are they in the various outcomes? How quickly do they think the world is going to change, and so on. So any belief that they have as part of their generative model is equipped with an uncertainty or a precision. And that means that the personalized generative model that explains this person's behavior is just articulated in terms of their prior beliefs. And usually it's just the precision, which is interesting. So how do you estimate the precision? Well, you take your favorite task that is sensitive to the kinds of beliefs you think characterize this cohort. So I mean, you actually identified one, a sort of go, no go, escape paradigm. You take your task, and then if it's a game theoretic task, or it's a sort of experimental psychology task, you then work out what the underlying generative model is and what prior beliefs would be required to make the responses required of this task. And then you can simulate an active inference agent doing this task. And then what you do is you adjust the priors, and in particular the precision of the priors, until the actual behavior of the subject, the person admitted into the undergoing induction for assessment, for example, or possibly in A&E, probably not in A&E, but in their first assessment, you adjust the precisions of your active inference model such that its responses emulate that of the patient. More specifically, you maximize the probability of the patient responses with respect to the precisions of your generative model. And then you've got a precise quantitative specification of the priors that matter because you've designed it. So this is called computational phenotyping. So this is practically how you'd use active inference with a well-designed, relatively simple task at the bedside to quantify the beliefs that matter that characterize this person's generative model. So this is a worked example which you can
Yes, thank you.
yeah. The question now, of course, is what is the paradigm? This one was it was an epistemic foraging, or sort of, do I go straight for my reward, or do I do a bit of exploration first? Right. So sorry, my doorbell has just gone. Yeah, so this is quite an old paper now, but I repeat, in fact, yes, it's 10 years old. But if you were interested in following this up, I'd recommend looking at the work of Ryan Smith, who has deployed this in addiction and depression, in a number of psychiatric disorders, and has also done validation follow-up studies to look at retest reliability of this kind of approach. It does require somebody who's skilled in active inference modeling, because basically what you're doing is you're building in silico a little digital twin of this patient just for this particular task. Just, this very narrow context that you've very carefully chosen. And in principle, if you can do that, then you can do longitudinal follow-up studies and just track the changes in the person's prior beliefs. Hopefully, as you're relaxing them through stimulation therapy or psychedelics or whatever whatever your CBT, whatever therapeutic intervention you're doing. But it does beg the question, what task? Now, you've already identified your favorite task. I just put this. We've done that one. So this is Adam Linson has worked on sort of stress responses to stress. I just put this up as an example. If you just forage the literature, you might find key kinds of tasks that can be modeled and written down and generating the kind of data that you could observe, such as eye tracking data or choice behavior. There is even some work, not this work, but there is some work in terms of simulating heart rate variability in ECG traces as well. So there is in the literature existing off-the-shelf models of certain tasks or situations that might be relevant for suicide. However, I don't know that there is a go no go of the kind that you said, but there might be. So it'd be worthwhile just seeing whether something out there has been modeling it. And once you've got that, then you can use that to do the computational phenotyping in principle. The final application, practical application, which you might find practically using, is actually deploying that dynamic causal modeling, which was talking about coupling between different brain areas, to general complex system modeling, in which you now treat the data, the dense data that you might get from Fitbits or sort of semantic analysis of the iPhone use, so weekly or daily data. Try and fit it in terms of the underlying causes of fluctuations in various attributes or aspects of those data. So this is basically generative modeling, not generative AI. This is generative modeling of every kind of marker that you could possibly imagine that has been caused by a latent state of pathophysiology and psychopathology. But you don't know the structure of it, so you just posit a fairly expressive dynamical state space model of, and you just literally label it sort of pathophysiology with 3 dimensions and psychopathology with 4 dimensions, and somewhere in this 4-dimensional space that will generate these data. What is these data? It could be a clinical diagnosis, or it could be repeat the sort of frequency of social media interactions, or something from a semantic analysis, or the heart rate variability. So all of these, it's a way of, if you like, summarizing, capturing the causes of the data, where those causes are specified by your causal model or your generative model in terms of pathophysiology and psychopathology, which you could refine and nuance and make more and more biologically plausible as you understood the mechanisms. But the general idea here is to actually, I repeat, very much like weather forecasting or infectious disease modeling, actually have a model under the hood that explains your data. And then if you can parameterize the data that you've seen so far, then you can roll out into the future. And then you can do forecasting, scenario modeling, intervention modeling. So this is something else that you might in the future want to bring to bear once you've got the data in play. One of the reasons I put this up is you mentioned high top. So Roman Kotov is one of the movers and shakers of the high top project. So this illustrative application actually used Roman's data from high top. So the ambition is to sort of make these models more and more expressive and fit for purpose, and ultimately try to get at the latent structure, which is not very well illustrated here, but never mind, the latent structure of psychopathology and pathophysiology and all the ways it can be expressed to the clinician and indeed the patient. And and from the point of view Witkop is to actually look at the underlying dimensionality of pathophysiology and sort of get a much more evidence-based, data-led or modeling model evidence led approach to pathology, which I imagine you could apply in the context of suicide. So how many kinds of sort of either pathophysiology or psychopathology, if it is pathology. There could be the altruistic suicide, there could be the
Sure,
psychotic
right.
suicide, there could be the sacrifice suicide.
Right.
There may be different dimensions here, and in principle, if you had enough data and it was longitudinal, you could characterize the within and between subject variability in terms of how many dimensions of pathophysiology or psychopathology do I need to explain these data. It's a long shot, but if you're interested, and there are people working in that, as I say, sort of primarily motivated by the Roman cutoff from Witkop to make as much sense as possible from of the Witkop data. Finally, I just wanted to come back to potential people you might be interested in talking to, who might be useful allies or possibly collaborators. Well, some aspects of the Spartan project reminded me of the aspirations of a group of people in Barcelona who run a company called Neuroelectrics, but also they're academics and they also have not-for-profit computational neuroscience ambitions, led by Giulio Ruffini. And interestingly, he has a special interest in plasticity, a different kind of active inference, but very closely related, mathematically predicated on complexity, but also recently applied to the EU and failed to look at the interaction between talking therapy, I think CBT, and 5-HT2A psilocybin intervention. So very much in the spirit of some of the interaction that you were talking about, but in this instance, not using ketamine or NMDA. But specifically going for the serotonergic system, which of course takes us back to Rebus. I don't think it was ever funded, but I imagine that they will try again. I think you would enjoy talking to this group.
Wonderful.
Simply because they also are experts in brain stimulation. So he's actually the CEO of Neuroelectrics, about Neuroelectrics, and this is their vision, which has some of the key words which you like as well. They're not as big as you, and probably not as experienced as you, but they are. They certainly have the same kinds of sentiments and same commitments to a mechanistic, and principled approach to personalized medicine using brain stimulation and a sort of formal understanding of what's going on. So if you contact, I repeat, his name's Giulio Ruffini, please send him my very best wishes.
I'm gonna do that.
And that's it.
Well, sir, thank you so much for your time again. This has been wonderful as always. I so much to think, and I will definitely work at Ryan Smith as well. This has been as usual. Well, usual. It's our second time, but it's been equally transformative. Thank you for your time, and I will absolutely. I love this idea of identifying the right test for the right model for the right individual to do it in a first principle rigorous way around these ideas, and getting someone on my team who has that particular expertise, I think is critical. So thank you so much for all of the papers, all the work, all of the just again tremendous contributions throughout. throughout your career. It's an honor to speak to you. Thank you.
Yes, you're very, very gracious. I admire your energy. But given we're both about to be grandparents, you've got incredible energy and sort of good citizenship, getting this science applied in a way that really matters. That's very impressive. Anyway, you should go and get breakfast now, I think.
All right, sir. Well, thank you so much. Thank you to everyone else. Appreciate all your time and comments. Have a wonderful day. Thanks so much. Take care.
Thank you, Carl. Thank you,
Yeah.
Gregory. Thank
Thank
you
you,
again.
Will.
That was a great
Appreciate it.
presentation. Super interesting.
Thank you.
All right. All the best.
Bye-bye.
Have a great rest of the day.